Thank you so much to Dr. Vaibhav and Dr. Ashok for inviting me here. And the wonderful talks before me, it feels like we're entering the age of science fiction now. So my talk will also take that a little forward. I'm Dr. Adarsh from Hyderabad. So the topic is, the robots have arrived, how far will we go? First, we need to know the definition. What is robotics? It's an interdisciplinary field that integrates computer science and engineering. It involves design, construction, and operation of robots. So what's a robot? A robot is a machine capable of carrying out a complex series of actions automatically, especially one programmed by a computer. But forget about all this. What we know, what is a robot? Robot. That's what we know as a robot, right? But it's not actually the case. When we see science fiction, we have all these are our idea of what a robot looks like. But if you see robots nowadays, outside of medicine, you have things all over. You can use it for, like, you have this particular pill dispenser, tells you what pill you have to take at what time of the day. You have a suitcase falling around. You have a robot that can cook for you. And you have these superb basketball robots. You can score from any part of the court. So what about robots in the surgical field? So of course, I think most of you are aware of the Da Vinci robot for general surgery and the NeuroMate for neurosurgery. These are the first robots which came into the public domain. Everybody knows about these robots. At least the doctors know about these. So I'm talking about the orthopedic robot, the arthroplasty joint replacement, and specifically the Stryker Mako 4th generation robot. This is what it looks like. It's not as fancy as the Terminator, but it's still a very useful thing. So there are, of course, robots from all the different major companies. The Zimmer has Rosa, there's the Cori Navio, which is quite popular, then the Merrill Cubis, and Depu is coming out with the Velis robot very soon. So just to see a brief evolution of the robotics, there's the static planning, in technology in orthopedics basic. There was static planning before, like the templating. Then you had navigated execution, somewhere in the 90s. In the early 2000s, you started getting navigated freehand tools like the Cori, the Navio. And now we have the robotic arm-assisted surgery like the Mako. The brief timeline again. So in around 90s, again, there was a computer-assisted. 92 was the first robot for arthroplasty, which is the RoboDoc, which later on became what we know as a QVIS right now. And then the Caspar, which is a German robot. The main timeline is for the Mako in specific. 2006 when it was formed. It started off with a partial knee, the Mako. Stryker Mako was for partial knee in 2009. 2010 they got total hip as well. In 2012 they come up with the Restris hip system. And at the same time Smith & Nephew came up with the Navio. Then around 2016 is when they got the total knee replacement. And now they have an upgraded software for the hip as well, which I'll be talking about in the later slides. So how does this differ from navigation? Everybody thinks navigation also did come into the picture and cause a lot of noise recently. But how is this advantageous over navigation? Of course, you have 3D CT image-based technology now. So you have better understanding of the pathology and the location of osteophytes, the quality of the bone. You can actually do pre-planning. It gives you accurate sizing, shape matching of the femur. And of course, you have the well-defined haptic boundary, and it helps you execute the plan that you have made. So if you think about it, navigation is like a planning tool. It's going to tell you where you have to start and where you're going to go. I need to come from Hyderabad all the way up to Mumbai. It's not going to tell me if I'm making any wrong turns or if there's any road closures. But robotic, it's going to tell me, take a right here, there's a dharna going around here, or there's some Bharat. It's going to tell me where to go and how to avoid such roadblocks. That's what robotics is. Does it do everything? No, it doesn't do everything. It only assists us, and that's how it should be. I'm sorry, this is not working. Okay, so the reason why I'm mentioning this slide is you have different types of robots. You have the boundary control, like the Navio. There's a semi-autonomous, like the Mako, where you're still doing the surgery, but it's only assisting us. You have the completely autonomous, where you're just standing aside and letting the robot play havoc on the joint. That is the QVIS, okay? So that's a fully automated one. So these are the examples of the other robots. This is the Navio in action. If you can see, it's like a burr with the sensors on it. And this is the QVIS, where the surgeon is standing on the side and letting the robot sculpt away. Something like the 3D printing and everything, but this is burring away. Right? This is a Mako robot. This is what it looks like. So it is still the surgeon who's doing the surgery. Sorry, this video is not working either. And the saw is connected to the robot, and you have the haptic boundaries. So while you're moving, you can actually see this particular bone getting eaten away. It's not working? Okay.
Let's press on this.
So this Mako robot can do all the three, a total knee, partial knee, and total hip replacement surgery. But what's the need? We have such great surgeons. Do we really need the robots is the question. As I mentioned earlier, all the three. So I'm going to talk about TKRs first. The three main core features are A, B, C. That's how we like to split it up. A for accurate sizing. You can even recreate your PCO, posterior coronary offset, perfect gap balancing, B, and 100% precise cuts. So you have the, none of the videos seem to be working. Yeah. So we have the enhanced 3D planning. The CT scan helps to compile and give us the exact 3D anatomy of the patient. Any chance, or? Shall I go ahead? Yeah, none of them are working. No, this is a PPT. Okay. So again, you have the dynamic joint balancing as well. So we are going to giving stress to the particular joint, and you can actually see how much it opens up, and you make a plan as per the balancing. And of course, the haptic boundary is the best part of it, where it actually guides you and tells you how much to cut. It doesn't allow you to move outside your specific boundary, so you're not going to damage any extra bone, nor are you going to damage any of the soft tissues around. What about partial knee? It's like sculpting. Again, so you have a burr, it's going to help you burr away against all the bone over there. Again, for unicorner, I feel it has a higher value because it's such a precise surgery and it prevents overstuffing of the joint. Yeah, you can see over here, it prevents overstuffing of the joint, and you. Yeah. Okay. So this is. It's running there. Okay, can you go to the next screen? Right. Yeah. So this is how you burr away, and you can display this, please. So this is what the it looks like, the partial knee replacement. You have the screen, and you start burring away, and it helps you to have that sub-millimeter accuracy in the partial knee replacement. Okay, next, please. In the total hip replacement, the advantages, so you have challenges in placement and positioning of the cup, inclination and inversion, leg length, all these are now lost. In manual, you have a risk of always piercing through the thin medial wall, but now you don't, because it's going to make sure you stop where you need to stop. Next, please. Okay, as I mentioned earlier, it helps you in inclination and limb length discrepancy. Next. So all these things can be taken care of in one go. Cup size, femur size, cup height, depth, rotation, anteversion, inclination, offset, limb length discrepancy, and bone stock as well. Even in dysplastic hips, it tells you where exactly the best bone is. Next, please. Next. Okay, and you can go to the next one. I've already shown this video. Next. Next, please. Yeah. So the summary of the benefits. You have the TCAR, accurate sizing, perfect balancing, and 100% precise cuts. In partial knee replacement, next. It prevents overstuffing, and in total hip, helps in cup placement and avoiding dislocations. Next. Yeah, so again, very important thing to remember is, next slide. Not all robotic systems are the same. So whatever literature I'm talking about is specifically about the Mako. Next, please. Can I go ahead? Yeah. So it's only CT-based system that recreates a 3D image of the patient. It's the only one which uses the intelligent tool holder, which is basically no cutting jigs used. It has all 3 applications cleared by the FDA, and it has a system with haptic technology, and it has long-term studies with the triathlon implant and TKRs. So what does it mean for the patients? Less pain in the 90-day period, 92% satisfaction in 2 years. These are all studies I'm showing, and has less of everything: less pain, less time for discharge, and less requirement of physiotherapy. And this is for partial knee replacement. The accuracy is much higher with the robotics as compared to the gray. And of course, our journey, we started in Feb 1st, 2020, and it was launched then. Yeah, that's fine, we don't need this video. Go to next. Yeah, and so we've done more than 2,000 surgeries now, and the best part is the procedure time has come down. Initially, we thought it's going to take longer for the registration, etc., but now it's hardly taking 45 to 50 minutes. What about our outcomes? This is a day 2 patient who's able to, again, yes please. She's sitting down on the second day after a partial replacement. This is when we realized the value of this particular technology. Next. And this gentleman, this is 1 week after his surgery, bilateral partial knee replacement. Next. And straight leg raising on the day of surgery. I'm almost done, just another 2-3 slides. Okay, next please. And gross deformities also can be done with this technology. Next please. So we're able to do the gross deformities. Next, valgus knees as well, we're able to do very well. All we need to do is we've now adopted something as functional alignment. We're not married only to mechanical alignment, and that's how the robot helps us. Next. So as I said, you can do for valgus knees as well. Next slide, please. Okay, next. And this is a woman, we did a bilateral total hip replacement. And this is just within like 3 to 4 weeks of the surgery. Next. And why are we getting better results? Just the last slide. probably because we're maintaining the internal homeostasis of the knee. As I said, we're not married to mechanical alignment anymore. We're just keeping our implants in a bit of varus and rotating it as per the requirement, and we're reducing the amount of soft tissue release that we need to do. Okay, so that's titration of the bone cuts, and haptic control prevents any soft tissue injury and less time with the knee subluxated. Okay, this is our study where, next slide. A study where we're comparing.
We've run 10 minutes.
Yeah.
Can we wind up, please?
Yeah, this is the last slide. So we're doing a study where we're comparing in the same patient, one knee manual and one knee robotic, and we're almost collected around 100 patients now. We'll be publishing this very soon. The future, because how far will we go is the question. Now we have hip technology, which is going to tell us about impingement and spinopelvic abnormalities. It's going to get a shoulder replacement as well. And now they've adopted ortho sensor, which helps us exact pressure of the implants as well. So let's hope that the day doesn't come when the robots are sitting in the post-op room discussing with each other. I hope we are still doing the surgeries, but only assisted by the robots. Thank you.